Welcome, everybody. Great to have you here in another episode of the Coronary Corner. I'm here with my co-host, Dr. Manos. Brilakis. My name is Yader Sandoval, and we're really pleased and excited here today to be talking about this concept of virtual PCI, something that we've discussed in previous episodes, but today we're going to have just a dedicated discussion about what is virtual PCI. So, Manos, just to kick off the conversation, tell us about post-PCI physiology and why is this clinically relevant?
Thanks, Yader, and great introduction, and I think everyone will find it very useful. And as you said, the post-PCI FFR or physiology is something we don't typically do. And because we believe that most of the time we have a good result, and often we do intravascular imaging, so we're fairly confident in our results. But unfortunately, many patients don't feel the best after PCI, and in some of them, it might be because they have diffuse disease or for other reasons, but in many patients, the reason may be that the PCI we did wasn't the best possible result. And there was a study called Defined PCI that showed that in almost 1 in 4 patients who undergo PCI, and angiographically it looks great, when you do a post-PCI measurement with physiology, the post-PCI IFR was suboptimal. So there's definitely cases in which we think we've done a good job, but we may not have done a good job. And that can be either because we didn't plan properly in the first place and that lesion was not a great one to treat because of diffuse disease, or because the stent we placed, we didn't optimize it. And I think the virtual PCI can play a big role in the first part, which is to plan our procedure and see if we can plan it so as to have an excellent or as good as possible post-PCI physiology measurement. But maybe you can give us your thoughts on this. How often do you do post-PCI physiology? We now have angiographic physiology as well, which can simplify this. But how often do you do this, and have you found this useful?
It's a great point, Manos. And I think, as you mentioned, not long ago, post-PCI physiology was thought to be an academic exercise, right? Something that we would do in trials. But this has changed actually in a relatively rapid pace in recent years, right? Because of the issues that you mentioned. Now we have better wires and microcatheters that are pretty facile to advance after stenting. But I think critically, as you point, now even with the advent of angiography-derived FFR indices, it's very facile to do this on pretty much a routine basis. So now I think we've entered this area of a modern physiology portfolio, whether that's with wires, microcatheters, CT prediction, and even the angiography-derived FFR. That post-PCI physiology has, I think, really had a dramatic shift from something that was thought to be like, why are you doing this? Nobody does this. Or this is a hassle. You're only doing this in the investigational arena or almost academic, to something that you can do very practically. And I think sometimes we're humbled when we do this anatomical, great stenting, cosmetic, beautifully result. And you're like, oh my God, my post-PCI FFR is like 0.81. And I think has augmented our level of sophistication of how we think about coronary disease. And I know we're talking here a little bit about virtual PCI, but to me, again, taking a step back and thinking about this clinically, and you mentioned this when you were explaining how you thought about this, is understanding that coronary disease is not one disease, right? It's either focal, it's either this mixed phenotypes, or is it diffuse? And I think with any of these modalities, whether it's intravascular, angiography-derived, or with CT, we have now the tools to better understand what is the disease phenotype. And this is where I think if I had to summarize everything we're chatting right now, I would say it all comes down to case selection. And the CT component brings case selection before you enter the cath lab. And I think to me that really changes the equation. What do you think about this issue of case selection, Manos, and how can CT now play a role into some of these challenges that we recognize?
Thanks, Yader. And I agree with you that CT has become, in many cases, the gatekeeper to come into the cath lab in the first place. As we discussed in previous episodes, it be used to decide where it's going to go, in a small lab or in the bigger lab. It's going to be an experienced operator early in the morning or not. So CT can help planning the logistics of the procedure. But also CT can provide input on physiology with FFR-CT and other modalities, and one can get an assessment about the pressure drops across the coronary tree. Do we have, as you mentioned, disease that is mainly focal and as a result more likely to respond well to stenting, or more diffuse disease in which the efficacy of the outcome, the ability to improve the physiology, And as a result, the patient's symptoms and the clinical outcomes may not be quite as good as we think. And there are these clear-cut cases where you have a midfocal lesion that you know if you're going to fix this, you're going to be good. But many cases are in the gray zone where it's not really diffuse, it's not really focal, but it is unclear whether we should put a stent and how long should the stent be. And this is where having a tool that can help us do different simulations. I think you often mention the term digital twins, have essentially a way to do experiments without, before going to the patient. That can be a revolutionary tool because you can experiment and say, okay, if I use a 15 stent, I'm going to get a post-PCI FFR of 0.80, but if I do a 38 stent, I'm going to get a post-PCI FFR of 0.95. So this can dramatically change what we do before we even get the patient into the cath procedure. And this is something that I think you've been involved early on, and I think you had a paper last year about the correlation of what you predict based on virtual PCI versus on what was actually achieved. So maybe you want to give us your experience on this
Yeah,
and what you learned.
no, I think you touched there on several words that I think it's important that we elaborate for our listeners that I think not everybody's familiar with. I think one is that we will see more and more about this term of digital twins, right? Which is pretty much we're entering this era of artificial intelligence in which now we can do simulations and predictions and understand anatomy and physiology before we enter the procedures, including the cath lab, right? And this is a lot of kudos, I would say, to Charlie Taylor, who, as many of you know, was really the inventor, founder of FFR-CT. But now, many years ago, Charlie and his team really had the inception and thought of, can this tool of FFR-CT be used not only to establish whether there's functional significance from a diagnostic perspective, but can you use computational fluid dynamics? At the time, this was not called digital twins, but can you use computational fluid dynamics and pretty much simulate the coronary anatomy, simulate the physiology, and now if you remove the lesion and pretend this lesion did not exist, what would be the estimated predicted post-PCI FFR-CT? And that was the first technology that I'm aware of that really, I would say, was the first tool that was really completely, the inception was to support PCI planning, right? It's literally you click a button and you place a stent and the vessel opens, and now you can choose what stent length you're going to implant and how that stent length would influence your post-PCI FFR-CT. And this was the planner with Charlie Taylor and Hartfield at the time that really, I would say, was the first tool. I think we've talked now for several episodes about CT-guided PCI and our journey and different things. And I like to think that I like how Jonathan Leipzig talks about this, about how different people enter the journey of CT-guided PCI at different, levels. If you're getting into an elevator, everybody enters that staircase or elevator at a different stage, right? So in my view, I know you were doing a lot of the work with CT for CTO, but in my view, at least in my experience, I would say I immersed myself into CT-guided PCI through virtual PCI in the planner, because now you had a tool in your hands that easily showed you the 3D model of the coronary anatomy. You could see fluoroscopic angles, you could see the physiology, but now you could easily, with a click of a button, implant a virtual stent. So this is the planner. I know you, of course, used it as well. And I think it's important that we describe what the tool is, as we just elaborated, but the data that really supported this. And maybe I just talk about one that I know you're very aware of, and I think it's the P3 study. So again, Charlie validated this, originally this from I would say, in an engineering perspective, but this now needed clinical validation. So now Jerome Sonk, Carlos Collette, Bernard De Bruyne, at the time at ALS, did a very elegant study. If I recall, I think we're like 120 vessels or so. And pretty much what they did is a very systematic study, to your point, that at the time was really done investigationally. And they did hyperemic pullbacks, motorized pullbacks of continuous FFR pullbacks, and matched those post-PCI FFRs against those predicted by the planner, and just showed excellent agreement. Those were the clinical validation that really moved this from an engineering early digital twin concept promise to something that was clinically validated and then was incorporated into P4. Manos, I know you use this and are familiar with how this was used in P4. Maybe you can tell us about how you think about the planner being a component of CT-guided PCI within a randomized trial. So I don't know whether you can elaborate on how the planner was used within the context of P4.
Yeah, thanks, Yader, and thanks for providing that historical perspective as well. And I completely agree with you. And for many people who are using CT today to plan PCI, the planner was the entry point because the planner essentially eliminated a lot of the obstacles that were present to use CT. You don't have to learn any sophisticated equipment. It's literally plug and play. You open the system, the 3D coronary tree shows up immediately. You can rotate it. You can see which angle provides the best visualization of the lesion. And as you said, just with a click of a button and by extending the length of the stent, you could get an assessment of what the FFR was going to be after placing a stent. So it was a very simple and elegant way to leverage the power of CT for planning PCI and optimizing the way that stents are done. And this was the basis of training from early stage and remains an important component of training people because, again, it reduces the barriers to getting into the area. The beauty of this in P4 was that it was part of a complete planning process. One could select, again, the length of the stent. There were other components that have to do with the calcium, the need for advanced calcium modification that go beyond this, but the FFR-CT allowed you to have a good estimate for the length of the lesion. Now, the diameter remains still an area of controversy with CT because there's some questions about how accurately it reflects, so the diameter still remains an area of active investigation. But as far as the length goes, the planner can really make a big difference and did make a big difference in P4 in planning PCI for the lesions. And I think more and more people that used it have become more facile and then went into more detail in the other parts of the procedure. But maybe you can come back now on your findings and from our center when we looked at it in the initial cohort of 52 patients. And this was a real life. It was not like P3, but it was a real life. And what were your impressions about the findings?
Yeah, I think this was, and again, this is part of the reason we were describing the historical journey of what led to what. This went from an engineering concept from Charlie Taylor with developing the tool to the clinical validation in P3. In Europe, the P4 trial had been designed and had started, Carlos, in Europe, but then we had the ability to implement this clinically here at our center in Minneapolis. And we, I would say, still have one of the largest experiences out there on virtual PCI. We reported our initial findings last year, which were just on the initial 2-year experience. Actually, we just recently concluded our 3-year clinical implementation experience. And really, the whole concept was just to show, is this something that you can introduce into clinical practice in a facile manner and incorporate this within cath lab workflow. And again, this is published in Catheter Cardiovascular Interventions, was presented as an abstract data in TCT. The original cohort was modest, like about 52 patients. This has now reached almost 100 patients. But pretty much the whole message is that, yes, you can incorporate virtual PCI as part of the workflow. Those cohort of patients that underwent stent and incorporated virtual PCI did very well with very high technical success and procedural success. But again, importantly, that within now outside of the context in a clinical trial, you incorporate the prediction of post-PCI FFR using virtual tools and pre-procedural planning into our workflow in a very effective manner. We even improvised. This is something that at some point we should put into a picture or somewhere in a paper, but we even improvised, as you might recall, we had in the cath lab pretty much an iPad on wheels that pretty much we said, like, you can just bring this in the midst of the cath lab. You can pretty much just grab this iPad and play with your virtual stenting and do this in the midst of the cath lab. So I think that's something that we did. But again, Manos, I know you're aware of some of this. Part of the reason we're talking about virtual PCI and just is because I think this field continues to evolve. And I think, again, you alluded to how I think I would say we're still in the early phases of these issues of AI and digital twins. And now we're seeing global data emerging on this. I know you're familiar with the CT Compass data that was presented at TCT, and there's just been some data data at PCR presented on this. So I don't know whether you want to maybe elaborate on how this has shifted now from, again, an engineering concept to in P3, a clinical validation, to being incorporated into a clinical trial in P4 that I think all of us are eager to learn the results of that trial likely later this year. And that will be an important pivotal point in understanding depending the results of the trial. But there's already some randomized data that has been presented at TCT last year and at PCR this year, Manos.
Yes, Yader, and you're absolutely right. This was the first randomized trial of virtual PCI. It was done using the RACE system, and Kefei Du from China presented it. And it had very interesting results. It was used to plan PCI. And what was found is that patients who had the virtual planning were able to achieve much higher rates of a high FFR compared to patients who did not have the planning done. I think the message was that although the study was not powered for a clinical endpoint at the 1 year presentation at EuroPCR, there were trends for lower event rates in the virtual PCI guided group. But still, the idea is that you can achieve a better post-PCI physiology by using this virtual planning. And as a result, the surrogate endpoint of post-PCI FFR that was better in the virtual planning group will likely translate into clinical benefit when this is done in a larger number of patients in different sites. So this study really positions virtual PCI as a very strong component of contemporary PCI with a lot of promise for improving clinical outcomes, although that remains still to be determined in additional studies. And I'm curious to your interpretation and what you think the next step are for virtual PCI and getting it into day-to-day practice.
Yeah, again, this is a heavily discussed topic. Again, people that are either very passionate about physiology or those that are championing efforts in CT-guided PCI. And because as you pointed out, if we take a step back on this CT-guided PCI, there's whole package, as you alluded, of elements, right? Whether you're using CT for your guide selection, for your lesion preparation, for calcium, for angles, for interprocedural planning and physiology. And of course, there's a lot of different positions about how do we feel about physiology. I would say that if we take a step back, we're an evidence-based field, and we incorporate and consider things if we feel they're going to improve patient care, improve patient flow, improve clinical outcomes. And the way I think about virtual PCI is pretty much, yes, there's all this very exciting concepts emerging within CT-guided PCI, but if we take a step back and think from an evidence perspective, virtual PCI, at least in my view, has robust physiologic validation in P3, in which it was matching an elegant study against pressure wire hyperemic measurements. It was incorporated in the context of a large pivotal clinical trial in P4, which of course, I think the results will provide a major inflection point of how we perceive the component of virtual PCI. And later this year, we'll know the results of P4, which is, again, to remind everybody, it's a 12-month MACE, non-inferiority compared to IVUS-guided PCI. So again, even though virtual PCI was not the whole plan, it was an important element of the package that all cases that were randomized to CT-guided PCI, all the operators would be provided different potential options of how the virtual stent may provide a different post-PCI physiologic results. And now I really think this now with the recent data from CT Compass suggesting that there is a substantial absolute increase in your post-PCI FFR and a signal from the data from PCR showing that there's a reduction in target vessel failure. I think there's a little bit of a story that's coming here together. This is a very valuable element. Now, I think as we've talked about a lot of the technical issues and the data, I think it's important to take also a step back and say, why does this thing work? The reason this works, and you tell me what you do this with wires and catheters and imaging and whatnot, but if you ask me the reason this works is if we need to think about why would tool with CT used preprocedurally improve my post-PCI result? And I think the reason is because it reduces surprises, it enhances your procedural preparedness, right? Think about a case that has serial lesions but has diffuse disease. I think if we do not look at the CT, if we do not have a tool that allows us to plan this beforehand, I'll give you my pitch, and again, you tell me what you think. I think if I know this beforehand, I say, look, Yes, the critical lesion that it's 90%, we could cover this with a 15, 18 millimeter stent. But look, there's quite a fair amount of plaque associated with a significant pressure loss that extends beyond for 20 millimeters or so. And by going ahead and implanting a 38 millimeter stent, not just thinking about plaque, but thinking about physiology, we know that now the post-PCI FFR will go, let's say hypothetically, from a post-PCI FFR of 0.82 to one that, let's say, it's 0.92. So that's the way I, at least in my mind, I conceptualize how this improves clinical outcomes, because it really helps us understand what opportunities that there's for geographic mismatch, serial lesions, diffuse disease, and by understanding that beforehand, we can tackle that at the get-go rather than on the go, ad hoc, try to react to some of these decisions in the cath lab. Do you think that's the right hypothesis of why this thing works?
Yes, I think you're right on the money there. And again, we do this instinctively in the cath lab. We do say, hey, we see diffuse disease del AD, maybe you need something more. But again, it's the intuition sometimes can be misleading in these cases because the vessel can be diffusely diseased and not have a normal reference segment. And what you think is okay ends up not being okay because you're underestimating the size of the vessel and the pressure drops, as you mentioned before. So it helps make it more objective and more reproducible, what I think we are already doing in our day-to-day practice in a subconscious way. So it will help improve the consistency, it will make things more reliable and hopefully translate in improved patient outcomes.
Perfect, Manos. I think this is overall just a really good discussion about physiology that I think transitions physiology from a tool that we have thought solely about, is it functionally significant? Is it ischemic or not? As you pointed out, gatekeeper to the cath lab, to a tool that now physiology is being incorporated to PCI planning. I think you touch on a number of concepts, but I really love how you help us summarize the lessons of some of these episodes that we've had. So Manos, do you mind just maybe telling us what is the 3 key things that our listeners should take home from this concept of virtual PCI?
Thanks, Yader. So here are my takeaway messages. The first one is that virtual PCI is a new way to plan PCI, and it can be done with T, and it is accurate. So first of all, it's something that is feasible and it's accurate. It's not available in many places quite yet, but it's something that would likely become available. Number 2 is that it has clinical value. It can help you plan the percutaneous coronary intervention and be more efficient in what you do and have fewer surprises after you do the procedure in terms of improving the physiology and as a result also potentially the clinical outcomes. And number 3, this is something that will, I think, change the way we do things once it becomes more widely available. In the meantime, one workaround, if we don't have people who don't have access to these tools, is at least in case they're more complex and more diffuse, to actually take the time, as you mentioned before, and do a post-PCI FFR or any sort of post-PCI physiology to confirm that what you think you've achieved has actually been achieved, because otherwise we do have some surprises in which we believe we've done a nice procedure and we have a good result, but the result may not be as optimal as we think. So virtual PCI is here to stay, and I think it will have an increasingly important role in the way we function.
Thanks, Manos. Great discussion as always. Thanks to all for listening to this episode of the Coronary Corner. We invite you to join us in Denver at the pre-CVI workshop, where we'll be having a full workshop on all these elements from plaque to physiology and how to incorporate CT into procedural planning. Hope you can join us there. Thanks all.